This is Patrick Tassone. I'm joining you live from Columbia, Missouri. We're happy to have everyone on. It's a privilege to have worked with the three panelists that I've worked with so far, and I'm really looking forward to what they have to say tonight. To introduce them, joining us from Chicago, Illinois, is Dr. Barry Wenig. Joining us from Seattle, Washington, Dr. Brittany Barber. And joining us from Dallas, Texas, Dr. Zainab Farzal. They all have a lot of expertise in the topics you're about to hear from them, and we're excited to get underway. So thanks to the AHNS for allowing us to host this webinar. If you're not a member, here's information about how to join. Of course, the international meeting is coming up next summer. The call for abstracts is out, and the due date is coming up early next month. This is part one of a two-part series. The second part will be hosted by the Cancer Prevention Service, and it is on chemo prevention for head and neck cancer. It's coming up on December 2nd, and the invitation will be forthcoming soon. I'd like to give a little bit of an introduction to today's webinar, which is about modifiable risk factors for head and neck cancer. We'll be covering a number of topics in this order. First, we'll talk about vaping, which is a pretty hot topic. We'll talk about environment and occupational exposures as modifiable risk factors for head and neck cancer. And we'll also talk about diet and exercise. So why this topic? Well, I think it's timely because for many of our patients with head and neck cancer, traditional risk factors have changed. Here's a nice graph over the last, 50 or 60 years of cigarette consumption by adults and youth in the United States. And you can see it's basically at all-time lows. It's interesting in looking at this graph, this spike in youth smoking around the mid to late 90s, which is thought to be a direct result of direct-to-youth marketing, such as this somewhat hilarious but ultimately very sad Camel ad featuring Joe Camel and, for no reason at all, two jet planes. And alcohol use follows a similar trend, maybe not as dramatic, and we certainly see an uptick around the time of COVID in alcohol use. But overall, compared to historic highs, alcohol use is at a low as well. And so I think there's a lot of other things that we as providers have to learn about a patient population that is potentially at risk, but not from traditional factors. And that I think helps both us and our patients. And so I think I'm enthusiastic about this topic. I know all of the panelists are, and I hope that you in attendance are as well. I'd like to give just a brief introduction sort of about how these things are studied to put the remainder of the panelists in context for their expertise as well. And one of the challenges in studying things like exposures and risk factors is that we can't do a randomized trial. We simply can't randomize people to vape or not vape in an ethical way. And so oftentimes this is just done in an observational way, sometimes in prospective cohort studies, but a lot of times in case control studies. And so an excellent example of a very robust case control study is what's referred to as the ENHANCE study or ENHANCE trial that I think many of you are probably familiar with, that describes the synergistic effect of alcohol and tobacco on development of head and neck cancer. And you can see this was conducted with many thousands of patients at many sites around the world in order to provide robust data. And these cases and controls are matched along a number of factors. And throughout any of the data that are reviewed this evening, I think it's important in these sorts of studies to always remember where you get your data. Oftentimes, case control trials are run out of insurance registries or voting registries. Very interestingly, I think knowing the employment type is fascinating. For example, some of the early studies linking lung cancer to smoking came out of the UK and were specifically restricted to physicians who, aside from their smoking habits, had many other environmental and lifestyle factors in common. And so we're able to narrow it down to just smoking. When we do these case control studies, oftentimes the data are analyzed using logistic regression. I think most of us are familiar with that statistical strategy. And this allows us to identify associations as well as control for other factors if those factors are not controlled for in matching already. Some logical ones to control for are things like age, sex, education, race and ethnicity, and of course, site of disease or location of residence. The output that's typically given is in an odds ratio. But one thing that I think is particularly important to keep in mind when looking at these observational and often case control studies is the population attributable risk, or PAR. And that asks what % of a disease occurrence is linked to a risk factor. And what it also tells us is the potential reduction in disease burden if that exposure were completely eliminated from the population under study. And so to go back to that enhanced trial, the output on that in terms of the PAR, and I know this is a busy graphic that was in that paper, but the PAR for alcohol, tobacco, and then alcohol and tobacco together add up to 72. And so what that means is that if we were eliminating in this patient population all use of tobacco and alcohol, we would eliminate 72% of head and neck cancers observed in this population. Other things that I think are useful to consider when we're studying this is the absolute risk. On that topic, one thing I'll hear occasionally from patients is they'll tell me the story of how their this, that, and the other relative smoked and never got lung cancer. And that's largely true, I think. This is an excellent uh, study out of Canada. And this is a sort of a take-home graph. But what you'll notice about this graph is even though there's this dramatic difference in the development of lung cancer among non-smokers versus smokers, the top of this graph doesn't go to 100%. It just goes to 20%. And so the absolute risk is important to keep in mind, as well as the magnitude of an effect, of any effect that's been studied. So, for example, and I think this will be talked about later, there's been a large amount of lay press coverage of the risk linking red meat to colorectal cancers. And so one of the more robust studies on this identifies an odds ratio of 1.3, linking high consumption of red meat. And this is people who eat red meat every day, often multiple times per day, landing on an odds ratio of 1.3, whereas in that enhanced trial, the odds ratio was 5.73 for smoker drinkers. And so the magnitude of the effect is important as well. I hope that puts some of what you're about to hear in context. I'm excited to hear from our panelists, and I welcome them now.
Thank you, and for allowing me to be on this panel, and it's a pleasure being with these panelists. So I'm going to talk a little bit about vaping. I have a lot of information here, which I guess speaks to the fact that there really is no information. So I do have a lot of slides. I'm going to try and go through them as quickly as I can to be fair to the other panelists. So in 1974, Michael Russell came up with this statement that smokers smoke for the nicotine, but they die from the tar. And subsequently, Scott Gottlieb, who was the FDA commissioner in 2017, envisioned a world where cigarettes would no longer create or sustain addiction, and basically began the concept of THR, which we'll discuss, which is tobacco harm reduction. My spoiler alert is the following, and you can jump all the way to the end of the talk because this is basically it. The use of e-cigarettes remains controversial due to conflicting evidence, and there's currently no conclusive evidence that vaping directly causes head and neck cancer. So I have nothing to declare, no conflicts. I will say that approximately 10 to 15 years ago, I served as a literature consultant for R.J. Reynolds Tobacco, as well as Imperial Tobacco, but I've not had any association with either for at least the past 10 years. So this is my outline. We're going to start with the introduction. Just in terms of terminology, ENDS are commonly known as electronic cigarettes or e-cigarettes and have been commercially available since 2007. It was an invention accredited to a Chinese pharmacist. And each device is made up of a microelectrical unit, which gets activated by inhaling through a mouthpiece, which delivers propylene glycol nicotine solution. And that is vaping. Interestingly enough, Lorillard came out with an annual report in 2013. And I think these numbers are really telling. According to retail sales, in 2012, 500 million, excuse me, individuals used electronic cigarettes. In 2013, that number was between 2 and 2.5 billion. The global sales predicted at that time to reach 10 billion by 2017. And actual sales for 2024 are 13.98 billion, with the predicted sales for 2032 being 45.19 billion. This is in comparison to the overall tobacco market, which is estimated to be $100 billion. This just shows you a graph of cans of smokeless tobacco, and you can see that it has jumped significantly in use from 2023 through 2025. So vaping and smokeless tobacco are both on the march upward. I don't know if that's good or bad, but it's reality. And we all know as head and neck surgeons that traditional cigarette smoking, which is burnt tobacco, is a major risk for head and neck cancer, obviously, along with alcohol use. And the vapor of the e-cigarettes has been shown to produce or expose users to some known carcinogens and harmful compounds. There is a multiplicity of cellular and molecular studies that I'm not going to be showing you. But one of our panelists is an expert on this and has published quite significantly, Dr. Farzal, and I'm going to talk a little bit about one of her studies. Bottom line is vaping is not risk-free. Now, we do have some factors. These are what we do know, but what we don't know, which are uncertainties, is that we are missing some long-term data. It's lacking. To Patrick's point earlier, there are no population-level studies that link vaping alone without smoking to head and neck cancer. Many users are considered to be what we call dual users. That means smoking and vaping, or they have a past history of smoking. The amount of exposure, the device types, the voltages, the flavors, and the user behavior all affect levels of harmful compounds. And finally, molecular findings do not prove that head and neck cancer will develop, but rather show plausible mechanisms for this development. So as I mentioned before, there's this concept of THR, which is tobacco harm reduction. And this is an important point in the overall concept of smoking as well as vaping. And this is based on a very simple concept that humans or habits or exposures can be assigned a degree or a level of risk to an individual's health. And the idea that safer forms of tobacco or sources of nicotine are substituted by smokers who are unwilling or unable to give up cigarettes or nicotine. And there is a risk continuum, which goes from none or negligible health risk up to high level risk. So the THR logic is that you have to meet people where they are, and that THR will mitigate health risks that are associated with high risk behavior. And some examples, not of vaping, but in the real world, are that we have methadone and needle exchange programs and naloxone for opioid dependent individuals. We have condoms to prevent HIV and STDs, and we wear seatbelts and helmets to prevent car and bike injuries. So as you can see here, the continuum of risk goes from combustible cigarettes, which are the most harmful, all the way up to nicotine replacement therapy, with e-cigarettes falling in this area and smokeless tobacco in this area. So in a study that Nutt did in 2014 on the continuum of risk, he found that smokeless tobacco accounts for 7% of harm. Snus, which I will talk about afterwards as well, which is a smokeless tobacco product a smokeless nicotine product from Sweden, counts for 5%. ENDS or e-cigarettes are 4%, and combustible cigarettes are 100%. Patrick mentioned before the PAR, which is an epidemiological measure. There are no studies that I know of that have discussed PAR as it relates to vaping. But there is a study that comes out that shows that, that uses the Bradford Hill criteria of causation. And in this, it has concluded that there's no way that they could assign a strength of association to vaping because of the presence of confounding factors. And it's difficult to assess e-cigs as an independent risk factor for all cancers. So basically, there's no epidemiological profile that we could use currently that helps us study the effects of vaping. What we do know is that there's an aerosolization process which involves heat that's generated by electrical currents that goes through a wire that surrounds a wick that's saturated with liquid. And we have found that aside from the propylene glycol, which is generally the major component of a vaping solution, as well as some formaldehyde, there are other constituents as well. And as you can see these references here, they appear to be quite numerous. The constituents of the aerosol that generated by ENS and inhaled are more directly relevant to the health than the ingredients of the liquids. And the nicotine that's inhaled is similar to the amount of that in a tobacco cigarette. What is important, though, however, is the composition of the particles in e-cigs aerosol differs from that of the particles in tobacco smoke and outdoor pollution. So here's the work of Dr. Farzal, which shows the toxicological effects of e-cigarette use in the upper airway. And she did a scoping study. This is a combination systemic review and meta-analysis of 822 articles, of which 53 met criteria for inclusion. E-liquids are typically made of a combination of propylene glycol, glycerol, and flavoring with or without nicotine. And the most studied flavors were tobacco and mint/menthol. And the conclusions were that the exposure to e-cigs and aerosols and condensates and e-liquids can increase cytotoxicity as well as tissue breakdown. The cytotoxicity was seen in all the upper airway subsites except for the trachea following e-cig exposure. And e-cigs have an independent toxicological profile, which is enhanced with the addition of nicotine or flavorings that often vary. This is a study that came out 3 years ago showing inflammation and invasion in the oral squamous cell carcinoma cells that are exposed to electronic cigarette vapor extract, as well as inflammation and invasion. And I can show you multiple studies that are similar. I'm just using this one study as an example of the range of in vitro studies that have been done. But I think the most damning study for clinical application of tobacco harm reduction came out of the public health system in England in 2018. And these authors, who compiled a significant amount of data, came to the conclusion that, in their opinion, electronic cigarettes can help people quit smoking and reduce cigarette consumption. But that this was a fairly limited and the amount of data that they had to come to this conclusion was quite limited. So moving on to a little different concept, we hear a lot in the States about youth using vapes, excuse me. And I don't want to talk about that today, other than because we're here to talk about squamous cell carcinoma. And there's no data really that links youth use of vapes with the development of squamous cell carcinoma. But there is this concept of a gateway drug. And the thought is that the vapes themselves can act as a gateway to use of other drugs. And this is based on two longitudinal studies that came out several years ago, which indicated that an increased likelihood for smokeless tobacco users to become smokers by comparison to non-users of tobacco. The weakness of these studies and the concept of gateway is that any data fail to properly account for confounding factors. And subsequent studies challenge the accuracy of the regression analysis and the psychosocial predictors of smoking. And if you look at the Swedish data, there's no evidence of smokeless tobacco serving as a gateway to smoking among adolescents and young adults. So for the rest of the talk, I'd like to concentrate on what we as physicians view the problem is and how we deal with it, if we do deal with it. So this is a study that came out in 2020 on the nicotine risk perception among US physicians. And it's really very striking. There are a lot of misperceptions. such as females and younger physicians, are more likely to perceive risks for birth defects. Pulmonologists are less likely to misperceive nicotine as a direct contributor to COPD, and family practitioners more likely than oncologists are more likely than oncologists to misperceive nicotine as a carcinogen. What's important for us to know is that the primary risk of nicotine is due to addiction and dependence. This is another study from Mandersky, again showing that the concept, the perceptions of nicotine use are misperceived in the population that he studied, with his takeaway showing that improved physician education about tobacco and nicotine is necessary. And this came out from the U.S. Preventative Services Task Force guidelines, who recommend that clinicians ask all patients about tobacco use. More than 20% of smokers are non-daily or intermittent and do not identify as smokers, and we miss those when we ask questions. It's important to inquire about secondary smoke use. It's important to provide tobacco cessation interventions for those who use tobacco. And there is clear evidence that a brief clinician advice intervention to quit has a small effect on cessation, and only a small effect. So in the otolaryngology literature, we have three primary references to vaping, and they are more or less review studies. They're very good review studies, but they're not data-filled studies, except for that of Flack et al., who did a systemic review and found that there was evidence for in vitro damage, which we know of anyhow, but there was insufficient data to draw conclusions. So as far as we as head and neck surgeons and part of the American Head and Neck Society, we have to ask the question, why is it important to ask whether, from a public health perspective, is there an opportunity to educate patients? The CDC reported that in 2015, 68% of smokers expressed a desire to quit, and 55% reported at least one quit attempt in the prior year. But the successful cessation was only limited to 7.4%. So to that end, what we did is initiate a survey study amongst the members of the Chicago Laryngological and Otological Society. Excuse me. And we only had 80% responders, and they were found, I'm sorry, of the 80% responders we had, they were not familiar with the concept of tobacco harm reduction. So we extended this out to medical student attitudes towards vaping and harm reduction. And we did a cross-sectional survey study at 3 campuses of University of Illinois. We have 3 medical campuses in our state. And the medical students said that they were highly trained and mostly confident on counseling with respect to traditional cigarettes. Of the total number that responded, which was only 219 or 16%, the majority admitted that they did not receive formal education on e-cigarettes, with their most common source of information coming from social media and from online advertising. There were varied perceptions regarding the impact on health and usage as smoking cessation, and the conclusion of this study, which was presented as a poster at the American Head and Neck Society several years ago, was that there was a need for e-cigarette education and formal medical training. So we extended that a little further, and we did a study of otolaryngology resident education and perceptions in the United States. We distributed surveys to ACGME otolaryngology residents throughout the U.S., with 150 participants only responding at an 8.88% response rate, which was very disappointing. The majority of these said that they had not received formal education on e-cigs in training. And similar to the medical students, the most common resource of information came from social media, which is, I guess, is not surprising in these days. Within academia, the most common source of information came from patient interactions, meaning between patients and with colleagues. Patients commonly inquire residents about e-cigs for smoking, which it was a surprising result with 85% inquiring. I think that's quite high, and that's something we need to keep in mind. 60% of the residents rarely or never ask patients about e-cigarette use, and only 4.35% of the residents were not confident discussing traditional cigarette use, whereas 58.7% were not confident discussing e-cigarette use. So finally, we extended the study to the American Head and Neck Society and head and neck surgeons' attitudes. And we did a pilot study to identify the attitudes and perspectives of e-cigarette use and smoking cessation counseling among our cohort, the head and neck surgeons. And this was a cross-sectional survey administered to AHNS members. The response rate was only 15.1%, with 102 or 75% having an unfavorable attitude towards e-cigs for cessation. 58%, less than half, were familiar with tobacco harm reduction, and 63% of these routinely inquire about cigarette use. 38% believe that the benefits of e-cig for smoking cessation outweighed the potential risks. And those familiar with tobacco harm reduction were less likely to have a definite opinion on the benefits of quitting combustible cigarettes. And that was published in JAMA as well. Just one final topic to wrap up, and that is smokeless tobacco. Oral cavity squamous cell carcinoma is obviously a very serious health concern. And as I said, in Switzerland, in Sweden, there's a major push towards using a snus, which is basically snuff, as we call it here in the States, that's moist. It is much more popular than smoking in Sweden. And a meta-analysis was done that showed no association between snus and oropharyngeal cancer, esophageal cancer, stomach cancer, pancreas cancer, or lung cancer. The epidemiology is well described, and this study was designed to study disease risk from smokeless tobacco use with various endpoints. And the authors found that as opposed to the US, there is low N-nitrosamine products, which are common in Sweden. But any high-quality study failed to identify any association, with U.S. snuff containing 15 to 23 times higher levels of TSNA than snus. Another topic that currently has to be paid attention to among our profession is that of oral nicotine patches. This is a study that literally came out 2 weeks ago discussing oral nicotine and its use currently in the United States. It is on a major uptick, and something that I think we as head and neck surgeons have to be attuned to when we see patients as part of our questioning. So overall, there is no hard and fast data that shows that e-cigarette use is directly correlated to the development of head and neck cancer. And as it stands right now, it seems that tobacco harm reduction has the greatest likelihood and opportunity to help individuals get off their nicotine habit and minimize the chance of developing head and neck cancer. So I thank you all very much for listening. And Patrick, I'll turn it back over to you.
Thank you. That was great. That was great. A lot covered, I think, very well. Um, Next, if you're ready, will be Dr. Brittany Barber.
Can you guys see my slides? Yeah, perfect. Okay, well, thanks so much for having me, guys. It's an honor to be here with these other panelists who are just fantastic. I have no disclosures. So today we're going to talk very briefly about the changing epidemiology of head and neck cancer, Then we're going to go through some historical and emerging examples of both occupational and environmental exposures that seem to be imparting risk for head and neck cancer and keeping us busy. Part of the reason this webinar is being held is that we're all seeing a rise in the number of both early onset and non-smoking head and neck cancer patients in our practice. These are all patients that I've seen in the past year, often young patients, non-smokers, non-drinkers, with no obvious risk factors. The rise in early onset and non-smoking cancers was first noted about 25 years ago, and we have been seeing these patients in our clinic ever since. I would say that this makes up about 40% of the oral cavity patients I see now. With early onset cases, anyone watching the news knows that early onset cases are increasing in all disease groups globally, with cancers in these younger age groups projected to increase by about 11 or 12% over the next 15 years. This sort of implies a ubiquitous exposure, but nobody really knows what that is at this point. When I was training, we would talk about head and neck cancer as smoking or non-smoking, and if they were a non-smoker, they would say, "Why did this happen?" And we would just say, "Well, I'm sorry, it's just bad luck." But in reality, I think we all know that's not true. And tobacco and alcohol are just two small parts of an ever-evolving and complex exposome for each individual. And your cumulative cancer risk can be modified over a lifetime by exposures in our jobs, in our homes, and outside our homes. This is why we all have to use a suction bovie now. Some of them are directly modifiable, and we're going to hear about those from Zainab. But some of them are just a little bit less modifiable, and some of them are going to require large studies and policy changes in order to reduce risk. And I'll show a couple examples of that. Just a quick disclaimer, there's a long list of occupational and environmental exposures that we could talk about today. The ones I'm going to talk about are only a fraction, same with the ones on the screen here. This presentation is really meant to bring attention to this issue and to provide some support for those really tough, "why did this happen to me" type conversations in the clinic. One of the first historical examples of environmental exposures being linked to head and neck cancer was published in the early 80s, and this was with wood and metal dusts and occupations that involve them, so welding, electroplating, and sinonasal cancers. And while I think we all know about this association, I bring it up because I think, one, it led to the first realization that inhalant exposures were also dangerous for the upper airway digestive tract, not just lungs. And because it led to the discovery that some of these exposures were occurring in very non-traditional occupations. And I'll show a couple examples of that. So this was a small study. It was the first of many studies, but this body of work grew over time in larger and larger cohorts in multiple countries globally, leading to the classification of textile dusts as well as formaldehyde, which you heard about earlier, as human carcinogens by the IARC, and ultimately led to implementation of exposure limits to protect workers. These findings were then crystallized in a really large meta-analysis in 2015 that demonstrated relative risks with exposures to textile dusts and formaldehyde that are, similar in some ways to tobacco use and alcohol use. So certainly a risk factor to be aware of. Some of the same authors then created the National Sinonasal Cancer Registry, which was aimed at investigating sinonasal cancer cases that were thought to be resulting from occupational exposures. And they noted at least short-term exposures to these known carcinogens in cases in multiple non-traditional occupations: dressmakers, hairdressers, wool spinners, many jobs that we wouldn't typically associate with wood dust or formaldehyde. This was very much an exploratory study, in fairness, but 2 points that I want to make here are, this type of work and the work that we do through the AHNS and other collaborations are really valuable to our field in identifying ways to reduce our risk for cancer for patients. And I think, secondly, you'll see that there's a theme here throughout this talk and, earlier in Barry's talk regarding inhalant exposures and head and neck cancer risk. So the next obvious thought here is, okay, well, the sinonasal site is contiguous with the rest of the upper air digestive tract. Does occupational exposure risk extend to other head and neck subsites? And the answer is yes. Multiple studies have examined individual occupations, welding, firefighting, machine working, dry cleaning, construction, and many of which have inhalant exposures and found significant associations with upper air digestive tract cancers. This one study here was a large French study called the eye care study and showed very significant risks with all of these different manual labors. A kind of bigger study was earlier, Patrick brought up the AHNS Consortium. This is a fantastic group that has done a lot for our field. The most comprehensive study to date, looking at occupations and head and neck cancer risk, looked at over 20,000 patients from the AHNS Consortium, pooling 12 case control studies from 3 distinct geographic regions, and studied a wide range of manual labor occupations. Standard epi study, you can't really see anything that's on the screen, but trust me when I say most of them are manual labor occupations. They looked at the length of exposure needed to impart risk, the risk by subsite, and they controlled, of course, for tobacco and alcohol use. And the results showed an increased overall head and neck cancer risk with service workers, production and transport equipment operators, and laborers with a duration of employment greater than 10 years. And a few of those occupations even imparted significant risk with less than 10 years duration. So then they looked at occupational risk by subsite. And as you can see, for each of these sites, and I'll show a couple in the next slides, the risk is variable, but consistent risk is seen with machine tool operators, plumbers and pipe fitters, construction workers, carpenters, plasterers, metal workers. And it seems to be very consistent amongst the oral cavity, the pharynx, and the hypopharynx. And what I think you'll notice here is that a lot of these occupations, they involve particulate matter in close quarters, carpenters, plasterers, cement workers, they're inhaling a lot of the substances that they're working with. The odds ratios were most consistently elevated for laryngeal cancers for most of the occupations studied, implying that this inhalant route of exposure may be kind of a significant risk and a significant contributor to head and neck cancer risk. And so certainly working in close quarters with ambient particulate matter seemed to be a common theme amongst risk. So what do we know so far? So we know that inhalant exposures can impart risk for head and neck cancer at multiple sites. We know that the occupations that involve inhalant exposures can be associated with head and neck cancer at multiple sites. We see that the most consistent risk seems to be with inhalant route of exposure in close quarters. Well, what about particulate matter inside the home? Because that's an enclosed space, technically close quarters. What about that? Well, this was the first study to look at this back in 1995, indoor air pollution. It was a case control study looking at around 350 cases with over 1,400 controls from 6 different countries, primarily in Eastern Europe. And what they were looking at was indoor solid fuel heating with coal, coke, peat, gas, oil, wood, and head and neck cancer risk. And admittedly, the exposure times were long. So you see there, greater than 40 years. But a significant risk was seen for oral cavity, pharyngeal, laryngeal cancers with indoor solid fuel heating, primarily wood, with odds ratios, around the 2s to 3s. And so a follow-up analysis 20 years later looked at 18 studies from all continents spanning almost 40 years and examining in non-lung cancers, including oral cavity cancer, pharyngeal cancer, laryngeal cancers, and nasopharyngeal cancers. And they found similar odds ratios. So now you might be thinking, okay, well, some of these studies were 30 years ago now. No one I'll be treating in the US has these exposures. Nobody's using solid fuel heating. Well, first of all, I would say many of our patients, if they're older, they would have lived through an era where their house was heated with a solid fuel. We had a gas stove and a wood stove in my house when I was growing up, and I'm at least 25 years old. And secondly, I would say it's actually not even that uncommon now to see people with a wood as a primary heating source or a secondary heating source in their homes. Not everybody, but there certainly are some folks. So in 2009, over 2 million US households, that's households and not people, but households, were using wood as a primary heating source. And about 8 million more were using it as supplementary heating. Maine, for example, doubled its use of wood heating between 2005 and 2015, and all of this is thought to be because of rising energy prices around the 90s when people were installing these wood heating stoves in their houses. So many of these stoves are antique, they're unregulated models, they have high particulate emission limits, and so this is actually a relevant problem, especially as we start to see more people work from home following COVID. So when people are in their homes, they're exposed to these risks throughout the day. So now we know inhalant exposures, occupations involving inhalant exposures, and inhalational route of exposures with high concentrations of particulate matter. All of these things are risks for head and neck cancer. We know that household air pollution is associated with head and neck cancer. So what about particulate matter outside the home? So we're talking about air pollution, right? Air pollution has been shown to affect human health as early as 1993 in this seminal paper from the New England Journal of Medicine showing all-cause mortality was higher in 6 US cities with severe air pollution. And more recently, and probably more interesting to us, this past July, air pollution was shown to be associated with an elevated risk of lung cancer in never smokers in this paper from Nature. And what they found in that study was that the patients that were never smokers demonstrated an accelerated aging effect with shortened telomeres and increasing somatic mutations with higher and longer exposures to severe air pollution. Air pollution, whether it's by the particulate matter or by the content, has been shown to be associated with multiple other cancers: breast, bladder, prostate, urologic cancers, colorectal, hematologic cancers, ovarian cancers. And so it's not unexpected that it might be related to head and neck cancer as well. Particulate matter in the air can be categorized based on size, as you see here, and there are currently no standards for indoor particulate matter concentrations. But for context, the current EPA standards for outdoor air is an annual mean of less than 15 micrograms per meter cubed annually, and that's a mean, averaged over the year. Interestingly, the World Health Organization actually aims for less than this, and you can see they have interim targets for what they're aiming for. By and large, ambient air pollution is actually decreasing since the 80s, but this remains a concern going forward, and certainly in other parts of the world. When it comes to head and neck cancers, this study looked at the association between mean particulate matter concentration per year and head and neck cancer incidence for the years of 2011 to 2019 in 608 counties in the US. And particulate matter levels were kind of estimated using satellite data, meteorologic data, government agency data, and they put them into 6-kilometer grids across the US. And indeed, particulate matter levels were associated with higher incidence of oral cavity and pharyngeal cancers with an incremental increase in risk for every 1 microgram per meter cubed increase in particulate matter. Probably a little bit more interesting to us are these other two studies that looked at both the lag time and the subsites with this particulate matter and showed that oral cavity and larynx were significantly associated with higher particulate matter levels in the air and a pronounced effect at 5 years following the beginning of exposure time. Another finding just down below, another study similarly showed an incremental increase in risk over 90 micrograms per meter cubed. The study also showed an additive effect if you added tobacco into the mix on cancer risk. So now I'll leave you with these thoughts, inhalant and occupational exposures, indoor air pollution, ambient air pollution, all associated with head and neck cancer risk. Could these exposures be related to the increase in early onset and non-smoking cancers that we're seeing globally? Well, unfortunately, there's a paucity of data surrounding this question with only breast and lung cancers linked so far. However, I will tell you that there have been just a staggering number of pediatric cancers linked to air pollution over the past 10 to 15 years. And so I think it is a reasonable question to ask. And on this question, we'll have to stay tuned for now. So in summary, occupations with inhalant exposures can increase risk of head and neck cancer at multiple sites, with some studies showing a dose-dependent or relationship with length of exposure. Household air pollution is associated with increasing risk of head and neck cancer at multiple sites, and solid fuel heating is still very much an exposure to be worried about for some of our older patients or in certain states in the country. And ambient air pollution is kind of an emerging and increasing risk factor for head and neck cancer at multiple sites as well. And we'll have to stay tuned for evolving data looking at air pollution impacting cancer risk in our younger patients and our non-smokers. So thanks for letting me present, guys. And I'll turn it back over to Pat here.
Thank you very much. That was great. And I learned a new word, which is exposome. Very good.
I put that
Thank
in
you.
the free, Pat.
I appreciate that. All right. Last, we'll hear from Dr. Zainab Farzal, if she's ready.
That's great. I'm going to go ahead and share my slides here. Thank you to the AHNS for the opportunity and thrilled to be part of this panel. It's some awesome panelists. So I'll be talking to, can everyone see my slides, by the way? Okay, perfect. I will be talking to you today about diet and exercise in head and neck cancer prevention. Don't have any disclosures. So, I would say the majority of the data that we have is more so related to diet. So that's what I'll mostly focus on in this talk. But we'll touch a little bit on exercise as well as the synergistic effects of those two. And then briefly on diet during treatment and what we know about that so far. So when we talk about modifiable risk factors, obviously there's, the big three, but then dietary habits and lack of exercise are among those two in terms of our intentional intake or habits. Diet influences carcinogenesis through various factors, as you know, can contribute to oxidative stress, cause inflammation, as well as immune function modulation, or even directly just exposure to carcinogenic compounds that are in food or drink. But the good thing about diet is that it can also be protective as it can be harmful. These are some of the things that contribute to dietary risk factors. And I think, these top three are what contribute to a pro-inflammatory diet. Low intake of fruits and vegetables, included with a higher consumption of red and processed meats, as well as overconsumption of refined carbs and saturated fats. There's a paper out there that also suggests some micronutrient deficiencies might contribute. We'll talk about that later. And then I won't get into it as much for the purpose of this talk, but there's some data suggesting high salt content and pickled food intake can contribute to esophageal cancer. And then I think most everybody on this webinar is familiar with the association of betel nut use with oral cavity cancer. So what is a pro-inflammatory diet, or what is included in that category? Processed meats, they tend to contain a high level of saturated fat and preservatives. Red meats have advanced glycation end products that also contribute to inflammation. Refined grains like white bread or rice contain carbs and lack fiber. The sugary drinks that are on the market also have many compounds that haven't been tested great, contribute to inflammation. Processed foods are a breeding ground for trans fats. They raise your cholesterol levels, also contribute to inflammation. And then fried foods similarly do the same, have high levels of omega-6 fatty acids. High-fat dairy has saturated fats as well, and inflammatory proteins. So what constitutes a good diet? As I mentioned, majority of our data are on fruits and vegetables. They have important vitamins, vitamin C, E, carotenoids. These will be in like your yellow, orange vegetables like carrots. Flavonoids, these are your leafy greens, berries, etc. They reduce oxidative DNA damage. Whole grains provide fiber as well as antioxidants, improving gut health, lowering inflammation in the body. And then fish and omega-3s are also anti-inflammatory through certain byproducts like EPA and DHA. There has been, more recently research into the Mediterranean diet, and this kind of gained some favor because it sort of engulfs what we would consider a good diet, or a balanced diet, if you will. So there's, a high consumption of fruits, vegetables, legumes, whole grains, nuts, and olive oil, moderate intake of fish, dairy, and alcohol, and then the low intake of red meat and refined food or sweets. This has been studied by basically a diet quality index. There's just a few of these out there, but a Mediterranean diet score, you might come across some of these if you look at the literature on the Mediterranean diet. Going into sort of the fruits and vegetables will be the main crux of my talk. This is one major US study that looked at SEER data, looking at 30 different cancer types and combined it with fruit and vegetable intake data from the AHNS survey. And it basically estimated the proportion of and number of cancer cases attributable to potentially modifiable risk factors in adults who are 30 and up in 2019. And we talked about population attributable risk a little bit earlier. So you're seeing here the association of low fruit and vegetable consumption on cancers of certain head and neck subsites, including oral cavity, esophagus, pharynx, and larynx. And they call it a population attributable fraction here, basically the same thing as a PAR. And you can appreciate that basically there is low fruit and vegetable intake contribute to approximately 30% of head and neck cancers. This is a slightly less compelling study, but a large one and worth mentioning. This reviewed basically 500,000 US participants of the NIH, American Association of Retired Persons Diet and Health cohort. They looked at fruits and vegetables based on servings per day for 1,000 calories, finding that people who were in the higher quartile of fruit and vegetable intake had basically a 10% hazard reduction for head and neck cancer. So not that compelling, particularly when they looked at vegetables on their own. There was about a 1/3 risk reduction, or 2/3 the odds of having head and neck cancer compared to for those in the lower quartile compared to those who were in the higher quartile of vegetable intake. And then this was about 10% for the hazard ratio was about 10% for those who had, the decrease in the hazard was 10% for those who had higher fruit intake. You heard a little bit about the AHNS study earlier. I think this is one of the most powerful ones on modifiable risk factors. And it stands for International Consortium of Multiple Risk Factors. It included 22 case control studies with approximately 15,000 subjects. And they looked at fruit, vegetables, red meats, and processed meat. And they used a dietary pattern score. This basically combined high fruit and vegetable intake with low red meat intake, and basically a higher score translated to a better diet. So what they found was an inverse association with head and neck cancer for those who had higher frequency intake of fruit and vegetables. There is basically 50% odds of head and neck cancer in those who had higher fruit intake, and basically 1/3 decreased odds, or 2/3 the odds of developing head and neck cancer in those who had higher vegetable intake. The intake of red meat and processed meat had a 40% increased risk or odds of having head and neck cancer compared to those who had less. Overall, they found that a higher dietary pattern score was associated with a reduced head and neck risk with an odds ratio of 0.9. When we discussed the pro-inflammatory diet earlier, this was one study that focused on that coming out of North Carolina. The CHANS database is a nice population health study that expands, all of North Carolina and head and neck cancer patients over a very long period of time, actually. And they used what's called the Dietary Inflammatory Index score that was calculated from a food frequency questionnaire that was administered to both patients with cancer and controls. And the cancer cases were noted to have higher dietary inflammatory index scores compared to controls. What I found very compelling about this study is that they looked at the synergy between a pro-inflammatory diet with alcohol as well as that and smoking, and found that it had a significant additive interaction with the smoking relative excess risk due to that interaction, basically tripling your chances of cancer and almost doubling that for alcohol with a pro-inflammatory diet. Coming back to the Mediterranean diet a little bit, this is a systematic review and meta-analysis that included 11 case control studies, about 6,000 head and neck patients, 9,000 controls. And this study found a high adherence to the Mediterranean diet. It was significantly associated with a reduced risk of head and neck cancer, almost by 56%. From 3 of the included studies, they noted that higher fruit and vegetable consumption significantly decreased head and neck cancer risk, which is pretty on par with some of the other work that I've presented. Whereas looking specifically at legumes, fish, low meat intake, there wasn't a significant association. Briefly wanted to touch on micronutrients, and honestly, the data on this is not great. This comes from a study looking at 204 patients with head and neck cancer who were admitted to a rehab unit. And what they did was basically run a gamut of vitamin and mineral tests to see what was deficient. But what they found was quite interesting. The most common vitamin deficiency was vitamin D, deficient in 63% of the patients. And then you're seeing here vitamin B3, as well as zinc, iron, selenium were deficient in between basically 40 to 55% of patients. So there's something to be said about these vitamin deficiencies and patients taking their vitamins or having foods that are rich in zinc, iron, and selenium. These often include, foods like poultry, beef, or eggs. And notably, the micronutrient deficiencies were similar in patients who had and didn't have a history of alcohol abuse. So they didn't really carry over from the alcohol abuse deficiencies. Wanted to briefly touch on diet modification during treatment. Specifically, I think this has been studied more so for chemoradiation, but still don't have great data on this quite yet. But it's really based on the idea that, since tumor cells need glucose to thrive, maybe reducing that from an individual's diet decreases their availability to their tumor cells and might cause decrease in or slowing down of disease progression. So there is a study out of Iowa, basically a phase 1 trial. Its murine aspect basically had all mice injected with human head and neck cancer. They were fed either standard mouse chow or a keto cal diet, and then they were then exposed to ionizing radiation. The tumors were then harvested to study basically markers of oxidative stress. And they saw a slight improvement in tumor growth rate and survival for those who were on the keto diet, but again, small sample size and hard to quantify at this point. They also had, a patient arm looking at patients with head and neck cancer who were undergoing CRT who were placed on a keto diet. They found that honestly, many patients pretty immediately quit the keto diet. They had a hard time with compliance, and much of it was related to, their symptoms, nausea, fatigue. Some of them had metabolic changes like hyperuricemia. And for a lot of them, it was just one more thing to worry about while they were undergoing treatment. I saw a preprint of a study called KetoComp out of Germany. We'll have to kind of wait and see their whole paper to know their findings. But the preprint sounded compelling in favor of a ketogenic diet for progression-free and overall survival. They, in their preprint, at least had 7 years worth of follow-up of head and neck cancer patients on a ketogenic diet. So we will see. As a nice resource I wanted to share with you all, the Head and Neck Cancer Alliance website has actually wonderful recipes of foods that patients can make that are, I guess a lot of them mimic the Mediterranean diet, but certainly minimize pro-inflammatory components. Going on to exercise, similarly to diet, it reduces cancer risk through improving immune response and reducing inflammation. And then obviously lowering your body fat or BMI also contributes to that as well. As I mentioned, it's not as well researched as dietary modifications for head and neck cancer, but we do know that there's some synergy between improved diet and exercise. The main study I think worth mentioning for exercise is this one that was published in JAMA Internal Medicine a couple years back. And this basically pooled data from 12 prospective US and European cohort studies in which patients, or I should say subjects, self-reported their physical activity. So there is that component of it that might introduce some biases that this was self-reported. But they looked at 1.4 million participants who had high versus low levels of leisure time physical activity. And they found that physical activity was associated with lower risks of 13 different cancers, which included head and neck cancer, basically a 15% decrease hazard of developing head and neck cancer for individuals who perform moderate to high intensity leisure time and physical activity. The way that was defined, basically moderate intensity activity was 150 minutes of, let's say, walking per week. And then higher intensity was 75 minutes vigorous activity per week, like aerobics. Overall, while we talk about improving diet and exercise habits for individuals, I think there's certainly barriers to incorporating these modifiable risk factors. And working at a county hospital, I see this a lot. Generally speaking, I think there's overall low public awareness because we focus so much on alcohol and tobacco that we, I think, lose some of these other factors in the process. But importantly, there are socioeconomic disparities as well. We know that the incidence of cancer varies globally in higher income versus lower income countries. We also know that limited access to fresh produce and safe exercise environments can contribute to head and neck cancer potentially in patients who come from disadvantaged backgrounds. And that is certainly something that we need to work on moving forward. In conclusion, Healthy diet and regular exercise, basically, they complement traditional prevention strategies that we focus on a lot. Promoting lifestyle modification can really alleviate the global head and neck cancer disease burden. Things you can tell your patients, kind of the tangibles, obviously avoiding tobacco and limiting alcohol, but consuming 5 or more servings of fruit and vegetables a day, choosing whole grains over refined grains, and then engaging in regular physical activity, whether that's 75 minutes of vigorous activity a week or 150, 2.5 hours basically of walking per week. That's all I have for you. Thank you for your time. Here are my references.
Thank you very much. And thanks to all of our panelists. We'll conclude the panel. Again, look out for the second part of this in early December. And look forward to seeing everyone around at International Meeting, I hope.
Thanks, everyone.
Thank you. Thank you all.
Thank you.